Hi everyone, welcome back to ISC Psychology, and welcome to the final video of the personality chapter. We've already covered a lot of ground: type theories, Freud and psychoanalytic theories, humanistic theories, and trait theories. Today, we close the chapter with a question that ties everything together. How do we actually test and measure personality? This is one of the most frequently tested sections in board exams where accuracy counts. So stick around and I will share important ISC exam tips and key focus areas you need to pay attention to while revising. So how do we actually measure personality? Theories are useful, but how do psychologists and clinicians go about assessing a real person's personality in practice? This is all what we will cover today. And it is an area that ISC takes very seriously. The MMPI clinical scales alone have appeared as standalone 10-mark questions in past papers. So there are four broad approaches to personality testing that you need to know. First, self-report inventories, with the MMPI as a key example. Second, projective techniques, specifically the Rorschach Inkblot test and the Thematic Apperception test. Third, behavioral analysis, covering 5 specific methods. So let us work through each one carefully. The first category of personality assessment is self-report inventories, also called questionnaires. A self-report inventory is a structured set of questions or statements to which the person responds about themselves. There are no right or wrong answers. The person reads each item and indicates their response. Typically, agree or disagree, true or false, or on a rating scale. So there are some advantages of the self-report inventories. They are quite standardized, so everyone gets the same questions under the same conditions. They can be administered to large groups simultaneously. They can be scored objectively and compared against established norms. And they are also quite efficient and cost-effective. There are also some limitations. People may not always answer honestly. They may give socially desirable responses, or they may lack accurate self-insight. Some inventories try to address this with built-in validity or lie scales. The most important self-report inventory for your exams is the MMPI, the Minnesota Multiphasic Personality Inventory. So let us look at it a little more closely. The Minnesota Multiphasic Personality Inventory is one of the most widely used and thoroughly researched psychological assessment tools in the world. It was originally developed by Hathaway and McKinley in the late 1940s and has been updated. The current version used clinically is the MMPI-2. The MMPI-2 consists of 567 true or false statements. The person reads each statement and indicates whether it is true or false as applied to themselves. Statements cover a wide variety of areas, including physical health, emotional state, social behavior, attitudes, unusual thoughts, and experiences. The MMPI is primarily used in clinical and forensic settings to identify psychological disorders, to assist with diagnosis, and to assess candidates for high responsibility roles like law enforcement or the military. What makes the MMPI distinctive is its 10 clinical scales, each designed to measure a different dimension of psychological functioning or pathology. For your exams, you need to know all 10 scales by name and be able to describe the symptoms associated with each one. So a 10-mark question will typically ask you to name and describe all 10. So that will be 1 mark per scale. So we'll go through them shortly, but you need to remember to learn each one as the name and along with their key symptom descriptions. Do not confuse the scales with each other because they have very different and distinct symptom profiles. Scale 1, Hypochondriasis, or HS. Hypochondriasis refers to an excessive preoccupation with one's physical health and bodily functions, in the absence of any confirmed medical condition to explain the symptoms. A person scoring high on this scale tends to report numerous vague physical complaints, like headaches, fatigue, pain, or digestive problems, that are not adequately explained by any physical illness. They are preoccupied with their body and convinced that something is medically wrong, even when doctors find nothing. They tend to be self-centered, demanding of attention and sympathy, and resistant to psychological explanations for their symptoms. Scale 2, Depression, denoted by D. This scale measures clinical depression, not just sadness, but a sustained state of low mood, reduced energy, and negative outlook. A person scoring high on this scale experiences persistent feelings of hopelessness, worthlessness, and sadness. They lack energy and motivation and find it difficult to experience pleasure, a symptom called anhedonia. They may also have slow thinking and may not have much movement. They tend to be pessimistic about the future and may feel guilty about past actions. Sleep and appetite are often disturbed. Scale 3, Hysteria, denoted by HY. In the context of the MMPI, hysteria refers to specifically a pattern where psychological distress is expressed through physical symptoms, what modern psychiatry calls conversion disorder or somatic symptom disorder. A person scoring high on this scale tends to respond to stress and emotional conflict by developing physical symptoms like paralysis, blindness, seizures, or pain that have no clear organic cause. Unlike hypochondriasis or the fast scale that we discussed, where the person worries about illness, in hysteria the person actually experiences physical symptoms as a way of coping with psychological conflict. They often show a striking lack of concern about their symptoms. They also tend to be emotionally immature, attention seeking, and overly optimistic on the surface, while being psychologically naive about their own distress. Scale 4, Psychopathic Deviance, denoted by PD. This scale measures antisocial attitudes, disregard for social norms, and authority conflicts. A person scoring high on this scale tends to be impulsive, irresponsible, and prone to lying and manipulating others for personal gain. They have very little regard for social rules and conventions, and may show a pattern of violating the rights of others. They may also have a history of legal difficulties, substance abuse, or troubled relationships. They tend to be superficially charming, but lack genuine empathy or remorse. They often fail to learn from punishment or negative consequences. Scale 5, Masculinity Femininity, denoted by MF. This scale was originally developed to identify gender non-conforming interests and attitude. Specifically, the degree to which a person's attitudes, interests, and emotional styles align with or diverge from traditional masculine or feminine patterns as understood in the mid-20th century. High scorers in men are associated with aesthetic interests, sensitivity, passivity, and less stereotypically masculine attitudes. High scorers in women are associated with assertiveness, interest in traditionally masculine pursuits, and less stereotypically feminine traits. An important note for your exams is that this scale is one of the most controversial scales in the MMPI because its conceptual basis reflects outdated gender stereotypes. For exam purposes, describe it as measuring the degree to which a person's interests and attitudes align with traditionally masculine or feminine patterns, with deviations from cultural general norms noted at the extremes. Scale 6, Paranoia, denoted by PA. This scale measures paranoid thinking, the tendency to be suspicious, guarded, and to tend to feel persecuted or unfairly treated. A person scoring high on this scale tends to be extremely suspicious of others' motives. They believe that people are plotting against them, talking about them behind their back, or deliberately trying to harm them. They are hypersensitive to perceived slights and insults and may respond with hostility. They have an exaggerated sense of self-importance, are rigid in their thinking, and find it very difficult to trust others. In more severe forms, grandiose delusions and persecutory delusions are common. Scale 7, Psychasthenia. Psychasthenia is now a largely obsolete clinical term, but is used in the MMPI to measure anxiety, obsessive-compulsive tendencies, and irrational fears. A person scoring high on this scale tends to be chronically anxious, tense and self-doubting. They are prone to excessive worrying and rumination. They may have intrusive thoughts that they cannot control, and they may feel compelled to perform repetitive behaviors to relieve anxiety. They're often indecisive and have low self-confidence. Scale 8, Schizophrenia, denoted by SC. This scale measures the presence of thinking disturbances, perceptual distortions, and social alienation associated with schizophrenic spectrum disorder. A person experiencing high scores on this scale may experience disordered thinking, thoughts that are confused, fragmented, or disoriented, and they may have unusual perceptual experiences, including hallucinations. Scale 9, Hypomania, described by MA. Hypomania refers to the state of elevated mood, increased energy, and accelerated activity that is less severe than a full-blown mania, but still significantly departing from normal functioning. A person scoring highly tends to be highly energetic, restless, and overactive. They have racing thoughts and flight of ideas, and also may be irritable if their plans are distorted. They tend to be impulsive, grandiose, and overconfident. Finally, the last scale is social introversion, denoted by SI. This scale measures the tendency to withdraw from social contact and social situations, that is, to be reserved, inhibited, and uncomfortable in interpersonal settings. A person scoring high on this scale tends to prefer solitude and small, familiar social settings over large social gatherings. They are shy, reserved, and uncomfortable meeting new people. They may lack social skills and feel anxious in social settings. They are not necessarily unhappy, they simply prefer less social stimulation. This is a quick, helpful reference for all the 10 scales that are worth memorizing. I will give you a tip to help you memorize if you can remember this sequence. Helping depressed, hysterical people may prevent painful suffering. Here's support. So this is a memory device listing the order HDHPM PPSHS, or the sentence helping depressed hysterical people may prevent painful suffering. Here's support. The second major category of personality assessment is projective techniques. A projective technique is based on the idea that when people are presented with ambiguous, unstructured stimuli, that means images that have no clear or fixed meaning, they will unconsciously project their own feelings, conflicts, desires, and personality characteristics onto them in a way they can be interpreted. The rationale comes directly from psychoanalytic theory, because unconscious material cannot be accessed directly through self-report. So we need an indirect method, one that bypasses the person's defenses and allows unconscious material to emerge. Your syllabus requires you to know two projective techniques, the Rorschach Inkblot test and the Thematic Apperception test. The Rorschach Inkblot test was developed by Swiss psychiatrist Hermann Rorschach. The test contains 10 cards, each containing a symmetrical inkblot. Some cards are in black and white only, while others include color. Each inkblot is entirely ambiguous. There is no correct or intended interpretation. So what is the administration? The cards are shown to the person one at a time in a fixed order. For each card, the examiner asks, "What might this be?" or "What do you see?" The person can give as many responses as they wish. After 10 cards have been presented, the examiner goes back through each card in an inquiry phase, asking the person to clarify where on the card they saw what they described and what features of the inkblot contributed to their response. Responses are then scored across several dimensions. For example, did the person use the whole blot, a common detail, or an unusual area? What features drove the response? Form, color, perceived movement, or shading? Also, content. What was seen? Human figures, animals, anatomical structures, or objects, as well as popularity and form quality. How well did the response fit the actual shape of the inkblot? Was the response a common one or unusual? Patterns across responses are then interpreted in relation to established norms and clinical indicators. For example, excessive use of color with poor form quality may suggest emotional impulsivity. Many movement responses may indicate active imagination. Unusual content may indicate unusual thinking patterns. For your exams and for the Rorschach Inkblot test, you simply need to know that there are 10 cards, there are symmetrical inkblots, which are ambiguous in nature, and there are 2 phases, free association and then inquiry. Also know the scoring, location, determinants, content, and form, along with a brief paragraph on interpretation. Next, we come to the thematic apperception test, which was developed by Henry Murray. This test contains a set of 31 cards, 30 cards in black and white illustrations of ambiguous scenes involving one or more people, and one completely blank card. The scenes are deliberately ambiguous. You can see that people are present and some kind of situation is occurring, but the exact nature of the situation, the relationships between figures, and the emotional tone are all unclear. The examiner selects a subset of cards, typically 8 to 12, chosen for their relevance to the individual being assessed. For each card, the person is then asked to tell a complete story. What is happening in the picture? What led to this situation? What are the people thinking and feeling? What will happen next? For the blank card, the person is asked to imagine a picture and then tell a story about it. Stories are then analyzed for recurring themes, needs, pressures, conflicts, and the emotional tone of the narratives. Murray proposed a systematic scoring system based on his need-press theory, analyzing the needs of the characters, that is, what they want and strive for, and the emotional pressures, that means, the forces acting on them from outside. Themes that reoccur across multiple stories are considered particularly significant. For interpretation purposes, the assumption is that the storyteller projects their own psychological concerns, conflicts, desires, and interpersonal patterns into the characters and situations of their stories. A person who is consistently telling stories about abandonment and betrayal is more likely to be expressing personal fears and experiences. A person whose stories consistently involve strong characters overcoming adversity may be reflecting their own achievement motivation. Again, for your exams, you need to know that there are 31 cards in total, how the test is administered, that is, the person tells a complete story for each card, and how the analysis and scoring is done, according to themes, needs, and conflicts. The third approach to personality assessment is behavioral analysis, that is, observing and evaluating what a person actually does, rather than what they say about themselves or how they respond to projective stimuli. Your syllabus requires 5 specific methods of behavioral analysis, each to be known briefly. Method 1. Interview. The interview is one of the most widely used assessment tools in psychology. A trained assessor conducts a structured or semi-structured conversation with a person, asking questions designed to gather relevant experiences about their history, behavior, personality, and current functioning. Structured interviews follow a fixed set of questions in a fixed order, ensuring consistency and comparability across individuals. Whereas unstructured interviews or semi-structured interviews allow the interviewer to follow on more interesting responses and probe more deeply. Interviews allow the assessor to observe the person's manner, emotional reactions, thinking clarity, and interpersonal style directly. However, they are also susceptible to interviewer bias. Different interviewers may evaluate the same responses differently. Method 2. Observation. In observational assessment, the assessor watches the person's behavior in a natural or controlled setting, recording what they actually do rather than asking them to self-report. Naturalistic observation takes place in the person's real-life environment, home, school, or workplace. Structured observation places the person in a standardized situation, designed to elicit relevant behavior. For example, asking a child to play with a peer and observing social skills. Observation is particularly valuable for children and for cases where self-report may be unreliable. It also suffers from one limitation. People may behave differently when they know they are being watched. a phenomenon called reactivity. Method 3, nomination. Nomination involves asking people within a social group, peers, classmates, or colleagues, to nominate individuals who best fit certain descriptions or show certain characteristics. For example, in a school setting, students might be asked, "Who in your class is the most helpful?" or "Who do you most enjoy spending time with?" The nominations received by each person are tallied to produce a peer-based personality assessment. Nomination has the advantage of capturing how the person actually comes across to others in their natural social environment, something self-report and even observation may miss. Nominations, however, can also be influenced by popularity, friendship, cliches, or relevant events rather than stable personality states. Method 4, behavioral ratings. These involve asking people who know an individual well, like a teacher, a parent, a supervisor, or a therapist, to rate an individual on a specific set of behavioral dimensions using a standardized rating scale. For example, a teacher might rate a child on dimensions like cooperates with peers, persists when tasks are difficult, or manages frustration appropriately, using a scale from 1 to 5. Behavioral ratings combine the richness of real-world observations with the objectivity of a structured scale. Ratings, however, are subject to raters' personal biases, including the halo effect, where a positive impression on one dimension inflates ratings on others, and leniency bias, that is the tendency to rate everyone favorably. Method 5, situational tests. These tests place the person in a standardized controlled situation that simulates a real-world challenge or demand and observe how they respond. The situation is carefully designed to be relevant to the personality characteristic or competency being assessed. For example, a military or leadership selection program might place candidates in a leaderless group task, a problem to solve with no designated leader, and observe who emerges as leader, how they handle conflict, and how they respond under pressure. Situational tasks have the advantage of assessing actual behavior under realistic conditions, not just what the person says they would do, but actually observing what they do when faced with a challenge. However, they also suffer from some limitations. They are costly, time-consuming, and require trained observers. The artificial nature of even the most realistic situation may mean people behave differently than they would in the real world. This is a quick, helpful revision summary slide for you while revising. It lists all the tests that we covered today in this video, starting with the personality test of MMPI, moving on to the projective tests for Rorschach and Thematic Apperception test, and finally ending with behavioral analysis. Now that we have completed the chapter, let me take you through some board exam questions to demonstrate the pattern of questions asked and what examiners look for while marking answers. We will cover some examples of very short questions as well as long answer questions. Read through question 1. This is an application question, an MCQ. The answer is option D, self-concept. The reasoning is that Rohan is resisting temptation by analyzing the situation against his own understanding of who he is and what kind of person he wants to be. This internal evaluation, that is, this is not something I would like to do, reflects his self-concept, his perception of his own identity, values, and the person he sees himself as. Habit, on the other hand, would refer to an automatic repeated behavior, not a conscious moral evaluation like this one. Let's move on to question 2. This is on the trait theory. The answer is option C. Secondary traits have less impact on a person's behavior. Remember, this is Allport's contribution, not Cattell's. Allport classified traits into cardinal, central, and secondary traits are the most peripheral and situational, appearing only in specific contexts and having at least pervasive influence on behavior. Options A and B describe Cattell's source and surface trait distinction, not Allport, so don't get confused. Option D is incorrect because Allport recognized traits as internal dispositions, not just outward behaviors. Question 3 is on post-Freudians, specifically Erik Erikson's theory. The answer is option D, confusion, especially role confusion. According to Erikson, like we discussed before, adolescence is the stage of identity versus role confusion. When an adolescent is unable to effectively resolve this identity conflict, that is, unable to understand or establish a clear sense of self or who they are, the negative outcome is role confusion, a diffuse, uncertain self with no clear direction or commitment. Guilt is the negative outcome of stage 3, inferiority belongs to stage 4, and despair belongs to stage 8. So none of these apply to adolescents. Moving on to question 4. This is on the MMPI inventory. So now you see why you need to learn even the subscales of personality tests, because otherwise you will not be able to answer such questions. The answer to this question is option D. Ken has repetitive thoughts about something going wrong during his college interview and constantly worries about it. Psychasthenia, that is scale 7 of the MMPI, is characterized by chronic anxiety, obsessive thoughts, and compulsive behaviors. The person experiences intrusive, unwanted thoughts they cannot control and excessive worry and rumination. Ken's repetitive thoughts and constant worrying is a textbook description of this. Option A describes paranoia. Option B describes hysteria, and option C is closer to hypochondriasis. Finally, we come to question 5. This is a long answer question, for which I have already provided the answer key, so you know how the examiner will mark your answer. 1 mark for subpart 1 for naming, and 3 marks for the next subpart, where you will not only need to name, but also explain the methods. So for each, you should at least write 1 or 2 lines explaining the main criteria of administration and what each method seeks to measure. If any explanation is missing, the examiners will cut half marks, which will lead to you losing easy marks. So do be careful while answering such questions. That's all for today. We have wrapped up the largest part of your syllabus on personality. As always, please like, share, and subscribe to our channel for more exam-oriented content. And let me know if you have any questions. Which chapter do you want me to cover next? Let me know in the comments below. Bye for now.